A patient tells you, I get breathless just walking to the bathroom, my ankles are swollen, I feel tired all the time. You check the notes, previous MI, diabetes, hypertension. This is not just tiredness. This is not just aging. This is heart failure. And if you don't understand this topic properly, you will lose both marks and patience. Let's break it down completely. What is heart failure? Heart failure is a progressive clinical syndrome, not a single disease, a syndrome. That means a collection of symptoms and signs caused by structural or functional abnormalities of the heart. Something is wrong with the heart muscle. Either it cannot contract properly or it cannot relax properly, and the result, reduced cardiac output. The heart cannot pump enough blood to meet the body's metabolic demands. And when organs do not get enough blood, symptoms begin. Why do patients become breathless? Think physiologically. If the left ventricle fails, blood backs up into the lungs, pressure increases in pulmonary veins, fluid leaks into alveoli. That causes shortness of breath, pulmonary crackles, pulmonary edema. This is not random, it is physics. Pressure builds, fluid shifts, gas exchange suffers. Understanding this makes everything easier. Symptoms. Learn the logic. Patients commonly present with shortness of breath, persistent cough or wheeze, ankle swelling, fatigue, reduced exercise tolerance. Why fatigue? Because muscles are underperfused. Why ankle swelling? Because right-sided congestion causes peripheral edema. When you connect physiology to symptoms, you never forget. Clinical signs, raised JVP, right-sided congestion, pulmonary crackles, fluid in lungs, pulmonary edema, severe decompensation. Exams love signs because signs show you understand pathophysiology. Risk factors, very important. Higher risk in men, smokers, diabetics, elderly. Most common cause? Coronary heart disease. Always remember this. Ischemia damages myocardium. Damaged myocardium weakens contraction. Weak contraction leads to failure. In patients of African or Afro-Caribbean origin, hypertension is a very common underlying cause. That is an exam favorite. Comorbidities. This changes management. Heart failure rarely comes alone. It coexists with chronic kidney disease, atrial fibrillation, hypertension, diabetes, obesity, dyslipidemia, COPD. Now listen carefully. AF changes anticoagulation decisions. CKD changes drug doses. So management is never isolated. You treat the whole patient, not just the heart. Complications heart failure can lead to CKD, AF, depression, cachexia, sexual dysfunction, sudden cardiac death. That last one is why device therapy exists. Remember that. Types of heart failure. Now this is where exams become dangerous. Two main types. One, HFrEF, reduced ejection fraction. Ejection fraction 40%. The ventricle cannot contract properly. Systolic dysfunction, weak pump. This is the one where we have strong mortality-reducing drugs. 2, HFpEF, preserved ejection fraction, normal or mildly reduced, but the ventricle is stiff. It cannot relax properly. Diastolic dysfunction, symptoms are similar, but treatment options are different. Very, very important difference. Why a classification? This measures severity based on limitation of physical activity. Class 1, no limitation. Class 4, symptoms at rest. Exams love NYHA. Aims of treatment. Now we think like clinicians. Our goals are reduce mortality, relieve symptoms, improve exercise tolerance, reduce hospital admissions. If a drug does not improve survival or symptoms or hospitalization, ask yourself why you are giving it. Non-drug treatment, high yield. Never ignore lifestyle. Stop smoking, reduce alcohol, exercise appropriately, weight control, healthy diet, reduce saturated fat. Salt intake, less than 6 grams per day. Daily weight monitoring, very important. If weight increases by more than 1.5 to 2 kilograms in 2 days, fluid retention, report immediately. Fluid restriction, only if dilutional hyponatremia. And very important, avoid potassium-containing salt substitutes. Hyperkalemia risk. Exams love this trap. Device therapy, life-saving in HFrEF with EF 35%. ICD prevents sudden cardiac death. CRT improves synchrony of contraction. Devices are not for everyone. They are for selected high-risk patients. Drug treatment. Now we build step by step. Do not memorize randomly. Follow structure. Drugs to avoid in HFrEF, verapamil, diltiazem, short-acting nifedipine, nicardipine. They reduce contractility. That worsens systolic failure. But amlodipine, safe in angina. Exams love this contrast. Diuretics, symptom relief only. Loop diuretics, furosemide, bumetanide, torsemide. They reduce fluid overload. They improve symptoms, but they do not reduce mortality. Thiazides, only if mild fluid retention and eGFR 30. Always titrate carefully. Avoid dehydration and renal damage. First-line mortality reduction, core of HFrEF, ACE inhibitor plus beta blocker, licensed for heart failure. ACE inhibitors, ramipril, enalapril, lisinopril, perindopril, captopril, quinapril, fosinapril. Beta blockers, bisoprolol, carvedilol, nebivolol. Start low, go slow. Never withhold beta blocker because of age, diabetes, COPD, peripheral vascular disease, erectile dysfunction. Exams test this misconception. Let me tell you something honestly. We are not here just to hear big medical words. We are here to understand them. If I say loop diuretics and you just nod your head but you don't really know what they are, that is not learning. You need to ask yourself, what are loop diuretics? How do they work? Why do we use them in heart failure? Don't ignore the words you don't understand. Those small unknown words are the exact places where exam questions come from. Pause the video if you need to. Search the term, read it, understand the mechanism, because medicine is not about memorizing names. It is about understanding why. And when you understand the why, you will never forget the drug. So from now on, any word you don't know, don't skip it. Go and learn it. That is how real medical students grow. And I know you can do it. If ACE not tolerated, use ARB, candesartan, losartan, valsartan. If symptoms persist, add mineralocorticoid receptor antagonist, MRA, spironolactone, eplerenone, unless hyperkalemia or renal impairment. Special situation, ACE and ARB intolerant. Hydralazine plus nitrate, especially beneficial in African or Caribbean patients. Still symptomatic, specialist decision. Options include sacubitril, valsartan, ivabradine, empagliflozin, dapagliflozin, digoxin, amiodarone. Digoxin reduces hospitalization, but does not reduce mortality. Very common exam question. Monitoring, high yield when starting ACI, ARB, MRA. Check potassium, sodium, renal function, blood pressure. Before starting 1 to 2 weeks after. After dose increase. Once stable, monthly for 3 months, then every 6 months. If acutely unwell, recheck. When starting beta blocker, monitor heart rate, BP, symptoms, CKD patients, lower doses, slower titration. HFpEF management, mainly symptom control. Loop diuretics for fluids, specialist involvement essential. No strong mortality-reducing therapy like HFrEF. This difference is crucial. Advanced heart failure, breathlessness, common. Long-term oxygen, not routine, only if COPD or other indication. Another exam trap. Heart failure is not just a weak heart. It is neurohormonal activation. It is RAS overdrive. It is sympathetic overstimulation. It is progressive remodeling. And when you understand that, ACE inhibitors make sense, beta blockers make sense, MRAs make sense, you stop memorizing, you start thinking. In exams, one correct drug gives you 1 mark. In real life, one correct drug gives your patient years. So do not just watch this topic, master it, revise it again tomorrow, teach it to someone else. Because when you can teach heart failure clearly, you truly understand it. And that is when you become dangerous in exams. I am proud of your progress. Next time, we go even deeper into advanced therapies. Stay focused, stay consistent, and keep building your clinical brain.